All right, let's get into the Pitt Season 2, Episode 3. I'm Benjamin Jack. I'm an ER doctor. My co-host, Dr. Ajay, is off this week. He will be back for future episodes. If you haven't yet, check out our other episodes on the Appendix channel and make sure to like and subscribe. All right, here we go.
5 with Duperidol, puts him down at 5.
No, you can't give it without knowing his QT.
2 beats of a rhythm strip before we took off the leads.
Get me in here, get out.
That looks good.
All right, so patients who come in like this, we talked about this briefly on a prior episode, but this is generally just a high-risk situation. You have a patient who's agitated. You don't know exactly why. It's dangerous for the patient just to be in this kind of what we call a hyperadrenergic state. Their blood pressure is up, their pulse is up. They're a danger to themselves and to staff. And the presumption is maybe this person, could be on an illicit substance, or maybe this person has a behavioral health issue or a mental health issue. But that's not always the case. It might be that they are medically ill first. For example, somebody whose brain isn't getting enough oxygen can become agitated. And so we don't want to jump to the conclusion that this person just took something. We want to kind of get the situation under control and then assess the patient as we would any other patient.
Get off me, man. 2901, get out. Get out. 2710, Title 18, Section 1938.
So they gave him an intramuscular injection. The staff kind of restrained him temporarily and then gave him an injection in the muscle of detroperidol. The medications that they mentioned, olanzapine and droperidol, those are two different types of medications that have sedating properties, and those are often used in situations like this where we need to get a patient sedated. We may not know their whole medical history. They get into some technicalities here on the EKG, on the rhythm strip. They're looking for what's called QT prolongation. That's a particular type of rhythm abnormality that we see on the EKG that could potentially make one or more of those medications dangerous. So again, they're trying to kind of act with imperfect information and just do what's fastest and safest for the patient.
On the antibiotic vial?
Excellent. Mr. Digby.
Just Digby.
Digby, why'd you wait?
One interesting thing is that nursing is so complex, and it's something that we as physicians don't always see all the details of. They're talking about what to document for each of the medication administrations, all this different information. This is stuff that, I see in the chart in the emergency department, but I wouldn't know all the details to document it. It's just not something that we do on a regular basis. So thank you to all the emergency department nurses out there, especially for keeping all the details straight and, all the other amazing work that you do.
Marquis, 32-year-old restrained driver, auto versus motorcycle. 2, 3. Joy, you stay with me.
So we have a patient coming in who was in a motor vehicle accident. It sounds like that he was a restrained driver.
Stay with Dr. Alasimi.
Open skull fracture, tubed him for agonal respirations. BP 60 palp initially, started a liter of NS, but lost his pulse en route.
Okay, so we have two trauma patients coming in at the same time. This is getting to be a complex situation. The first patient that came in was in a motor vehicle accident and had altered mental status. His wife was at the bedside. She's saying, why isn't he talking? I think that they did the appropriate thing of taking the wife aside so that the team could focus on the patient, on assessing and resuscitating the patient. And then simultaneously, you have another trauma coming in, and it looks like this person's in cardiac arrest. So we had talked about this previously. Cardiac arrest in trauma is, always a bad situation and is very often, ends in the patient dying. Penetrating trauma, sometimes there are some more heroic measures that can be taken. Cardiac arrest in blunt trauma has a very, very poor prognosis. So let's kind of see how this unfolds here.
1, 2, 3. Joy, check his pupils. Somebody hand me a pair of scissors.
So it's a trauma. We're going to do ABCs, airway, breathing, circulation. So it looks like he's already intubated, and it looks like he's kind of jumping ahead to assess the patient's mental status by looking in his pupils. If somebody has pupils that are fixed and dilated, meaning the pupils in the center of the eye, the black part, are wide and taking up almost the whole eye, that can be a sign of increased intracranial pressure, which in the setting of a trauma would be from bleeding in the brain. So the idea is that if you get hit really hard in the head, it causes bleeding in the brain. That blood doesn't have room to go anywhere. It can push the brainstem into the base of the skull. That expanding hematoma, we call it, the expanding bleeding, basically ceases the function of your brainstem because it gets pushed through that area in the bottom of the skull. That causes your pupils to be fixed and dilated, and often that can indicate brain death.
8 millimeters, non-reactive.
AKA blown pupils fixed and dilated.
So there you go, blown pupils fixed and dilated. They're 8 millimeters non-reactive. So this is a very, very poor prognosis here. You have somebody whose heart is not beating, CPR is in progress. They have fixed and dilated pupils, which can be an indicator of brain death. And this person probably is not going to survive this accident, just, based on the information that we have so far.
Spontaneous eye movement, response to pain, GCS is 10, borderline for intubation.
No muscle tone, flaccid.
So they're using the Glasgow Coma Scale, GCS, to decide if this person needs to be intubated or not. So the question is, this person was in the accident, they have altered mental status, meaning they're confused, but are they awake enough to breathe on their own to protect their airway? So GCS is one of the tools that we use to determine that. They calculated this person's GCS at 10. It's a 3-piece score. 15 is normal, 3 is the lowest score. So the adage is GCS less than 8 intubate. If somebody has a GCS less than 8, they usually need a breathing tube. Not always the case, but that's a good rule of thumb. Here, they calculate his GCS at 10, and so, as she says, he's borderline for requiring intubation.
Pan scan with 3D reconstruction of the spine.
He's quadriplegic?
C3, 4, and 5 helps you breathe to stay alive.
So they're worried that when they do this initial neurologic assessment that he's not able to move his arms or legs, and they're speculating that that's because he has an injury in his cervical spine. So if you've ever seen somebody who's been in an accident who's in a C-collar like this, as we see right here, this blue and yellow piece around the patient's neck, that's preventing their cervical spine, the part of your spine in the back of your neck, from moving because they're worried that this person might have a cervical spine injury. So the reason that cervical spine injuries are such a big deal is that the nerve roots that come out of your spine, if you have an injury that's higher up in the spine, there's more of a chance of it affecting the entire body, including your breathing. So if somebody has a high spinal injury, meaning they're injured in their cervical spine high up, as opposed to, say, in their lumbar spine and your low back, that high cervical spine injury can affect all 4 limbs, it can affect your breathing, and it can make somebody quadriplegic as they are concerned this person might be. It's hard to make a definitive diagnosis of that when somebody's just arriving in the trauma bay. It kind of takes some time to do a more detailed exam. Sometimes initial neurologic findings can change over the course of the patient's treatment, but definitely want to keep this person in that cervical spine collar, that C-collar, so that if there is an injury, it's not worsened. And if there's not an injury, they'll prevent an injury from happening by keeping the neck immobilized.
CT results from Mr. Williams.
Oh, wow. Okay.
Basically, nobody's ever handing you an iPad with CT results. We see the results on the computer in the electronic medical record, and if there's a really significant finding, oftentimes we'll get a call from radiology, but that's like sort of for TV. Like, here are the CT results. More often, it's like we're doing 5 other things, then we finally get back to the computer and see the results.
Okay, clamped. Ogilvy, make the change.
Okay. All right, let her rip.
We saw a bit of this last time. So this guy has ascites. He has fluid in his abdomen, probably from liver failure. This is a common complication of liver failure. And that fluid in some patients needs to be periodically drained, as it is in this patient. So we take these big bottles. This is totally what it looks like. We take these big bottles and drain out sometimes multiple liters of fluid as the patient kind of hangs out there with a catheter in their abdomen. And it seems like this patient needs to come back frequently for this, which again is fairly common. Ideally, this isn't done in the emergency department. Procedure like this, called a paracentesis, can be scheduled as an outpatient for patients who need it on a recurring basis. People who don't have regular access to care, oftentimes they do end up with us for that drainage.
It's a brain tumor.
Well, it's a mass. About 4 centimeters in the frontal lobe. It could be many things. Infection, inflammation, a benign cyst.
Is it what made me fall?
Yeah, so this is always a difficult situation. So this guy, if you remember from previous episodes, I think he came in confused and had fallen. And then they did a CAT scan of his head and found a mass. So the CAT scan shows in this person's brain, it shows this finding, it shows something that's not supposed to be there. And any kind of mass, any kind of space occupying lesion is what we call it in the brain, can have all kinds of different effects, some of which include confusion and falling, weakness, numbness. So it happens from time to time that patients will come in with kind of vague symptoms, sometimes long-standing headache, or again, some of these new neurologic symptoms, and we'll do the CAT scan and we'll find something, we'll find a mass. And this is often exactly how the conversation goes, because we don't know exactly what that mass is. The patient's going to need more testing, probably a biopsy, to figure out like what is going on here. And also, we'll normally do a CT scan, a CAT scan first, which doesn't give as much detail as an MRI would. So it's like this conversation of, we found something, there's a problem, but we really can't tell you much detail about it at all. Thanks to Appendix for making this video possible. So Appendix is concierge primary care backed by a team of doctors. So the way that it works is you speak with one of our doctors, and then that doctor goes back to the rest of the team and discusses your case. We actually record that information and give it back to you so you can see a video discussion of how all of these doctors were debating your case, debating your care, and coming to a consensus about the best way to move forward. It's a unique model, and it provides an unusually kind of collaborative and high level of care for patients who join the practice. So check it out, appendix.com, and sign up today.
We'd like to keep you here and treat with dexamethasone, and then we'll need a brain biopsy to know exactly what it is.
Yeah, so there you go. This is great that they're keeping him in the hospital. They're going to give him dexamethasone. That's the same steroid that we give kids with croup to reduce swelling in the airway. When we give it to somebody with swelling in the brain, it reduces swelling in the brain. And oftentimes when we diagnose a new tumor, whether it's in the brain or somewhere else, we will try to keep patients overnight in the hospital just to get connected with that specialist care. It doesn't always have to go that way. If somebody has really good follow-up care and they can potentially see an oncologist the next day and get scheduled for any kind of testing that they might need, they might be able to go home. But usually it's just more comfortable for the patient and for everybody involved to just stay and get everything done while they're there overnight.
You're gonna cut open my head.
A CT-guided stereotactical biopsy with a blunt, thin needle, which sounds crazy, but it's actually pretty amazing.
That technology is amazing. The visualization that the surgeons can do to see exactly where in the brain they're approaching is really incredible. This is more detail than I would typically give a patient. I don't know exactly how they're going to go about a biopsy or like when that will happen or under what technique. So I'll usually defer that conversation to the specialist while the patient's in the hospital.
BP 95/67.
Have you ever had low blood pressure in the past?
No, sir. My blood pressure is always high.
Hold still, sir. No talking while we do the EKG.
I feel like I have this conversation. That conversation that just happened, word for word, is like, I get that line like every shift. So they're doing the EKG. The patient's blood pressure is low. We tend to worry more. It depends on the situation, but we tend to worry more about low blood pressure in the emergency department than high blood pressure, unless it's really high and I'm talking like above 180 or 200 systolic. If somebody's blood pressure is say 140, 150, 160 systolic, we don't want patients walking around with that blood pressure. Over time, that can certainly do damage. But on a single or two readings in the emergency department, part of that, the reason that it's high is probably because of the stress being there, along with some underlying untreated high blood pressure, hypertension. But if a patient has a single low blood pressure reading, say 80/40, that single reading is a pretty big red flag for us. A low blood pressure can indicate infection, can indicate blood loss. It's just a bad prognostic sign of something dangerous going on.
Why is he so altered? Could be concussion, maybe a small intracranial hemorrhage.
All will be revealed by the donut of truth.
Actually, something that we sometimes say, joking around, the magic donut is the CT scanner because it gives us so much information.
Well, you can't go into the CT with him, but you can wait just outside if you like. Princess, this is Nancy. Mrs. Yi's going to go with her husband to CT. Will you show her where to go?
Sure, come on in.
Thank you.
I like that they were able to bring the family member to bedside here. We're not always able to do that. It's more often the case that like patients kind of get their initial workup, especially in a trauma like this, and then the family member is brought to the bedside. It tends to vary based on the layout of the hospital. But yeah, here it's nice the family member comes to the bedside and can give the patient some comfort.
Hypokalemic periodic paralysis.
What is that?
It's a rare condition where potassium gets shifted into the cells, causing profound weakness.
Cool. So the guy's CAT scans come back and don't show any bleeding in the brain. They don't show a broken neck. So this initial suspicion for a cervical spine injury is now lower on the list. As they say, a normal CT doesn't definitively rule out a spinal injury, and MRI is more sensitive for that. But then the potassium comes back and it's profoundly low. So potassium normally runs from 3 to 5. It's a very narrow range that the body keeps potassium at normally. So potassium this low can cause all kinds of unusual symptoms, including weakness. So they're going to give this guy potassium, and maybe that's his problem. Why his potassium is low, we don't know yet, and it's pretty unexpected, but it does provide an alternate explanation for what's going on.
Me and my sister are making bracelets, and I put beads up my nose.
This is like one of my least favorite complaints. Kids put beads in their nose or in their ears. They can be really hard to get out. And kids this young, even if they were fully cooperative, they're hard to get out. But kids this young are obviously not cooperative. They're scared. It's painful. So it ends up often being like a huge ordeal. Sometimes we have to sedate kids just to be able to get these beads out. So let's see what happens here. But I don't like this complaint at all.
Yeah, I tried blowing in his mouth, but just got a little snot on my cheek.
Ain't for effort, Dad. Okay.
Yeah, we try that actually. So there's this technique, they call it the mother's kiss or the father's kiss. You occlude the opposite nostril and try to have the parent blow into the kid's mouth to try to like force air up and through the other side of the nose. Works sometimes, but not always. I just pulled up a study here to see how effective this technique is. So here's this efficacy and safety of the mother's kiss technique, a systematic review of case reports and case series. They say that 59% of the attempts were effective. So about 6 in 10, which is, okay, but not great.
Blue one. Afrin, benzocaine, Cas extractor.
Yep. Dad, looks like we gotta go up and get him.
No way, he's...
Yeah, so this might be okay here. They're saying it's below the inferior turbinate, so it's not high up, like they can see it, and maybe they can get it out. They call for a numbing agent, and Afrin, which is the nose spray that you might have used if you've had a stuffy nose, that constricts the blood vessels. They give some benzocaine to numb the nose. They're gonna try to pluck it out.
Bag him. Starting compressions, charge at 200.
Low potassium can harm electrical activity in the heart.
Charge.
Clear.
Resuming compressions.
So that's the other problem with potassium being very low or very high. Low or high potassium can cause electrical disturbances in the heart. And so in this case, this patient goes into an abnormal heart rhythm. His heart suddenly stops beating. They initiate CPR. So that's actually the more feared complication of an abnormal potassium, and the one that we more commonly see. Again, this patient's potassium is profoundly low.
Oh, shit. We need a gurney.
Weak carotid, shallow breaths.
Did she vasovagal from stress?
Can't assume that. Positive seatbelts. Oh, shit. Hey.
This is also a great case. So she's talking to her husband. She fainted. And this does happen a lot of the time in the emergency department. Family members will become overwhelmed. They will faint from the situation, from seeing blood, or just, from the stress. And that's what they call out initially. They say that this might be vasovagal. Vasovagal is when your blood pressure drops because your body's overwhelmed with a situation that's, again, either it's causing your blood vessels to dilate and causing you to be stressed. And that's why most people faint in everyday circumstances. But here, she is a trauma patient. So remember, she was also in the car accident. Dr. Rabi takes off her clothes and sees this seatbelt sign, this bruising on her flank. And so, wait a second, this is not a vasovagal kind of fainting episode. She's bleeding. She was in a major trauma. She's got blood loss internally, and so he recognizes that right away and calls for a blood transfusion for O-negative blood, emergent blood, and she's gonna get blood to stop this assumed internal bleeding.
That's it. Wendy's pile. Yellowish bottle, little round blue pills, just like I said.
Propranolol?
Bingo, little lady.
Okay, yeah, well, this makes a lot of sense now.
It does make a lot of sense. Propranolol is a beta blocker. It lowers the blood pressure and slows the heart rate.
How many pills did you take?
I think 4, maybe 5.
That is a lot. Okay.
Yeah, so that's pretty dangerous, that propranolol overdose. So propranolol is a member of this family of medications called beta blockers, and they lower the heart rate, they lower blood pressure, and overdose can be really dangerous because a low heart rate and low blood pressure, if either is low enough, then your body's not perfusing with blood and it can be fatal. So we take beta blocker overdose pretty seriously. In the emergency department, we'll often consult toxicology or poison control. Toxicology is a very kind of specialized topic. Like there's so many different medications that people can overdose on. And so we have subspecialists who know a lot about that particular topic. And so we'll often consult a toxicologist to figure out what to do about this particular overdose of this particular medication that the patient took.
Good vitals in the field, no distress. She refused to sign in.
Next time I'll use my x-ray vision goggles.
Let's get her upstairs.
Yeah, so they fast her. So they do an ultrasound of her abdomen. FAST is focused assessment of sonography and trauma. So it's a quick look in the abdomen to see if there's any free fluid. In the setting of trauma like this, what we call free fluid, like fluid moving around in the abdomen, is blood. It's assumed to be blood because somebody has bruising on their abdomen, they were in this accident, they have low blood pressure. FAST showing fluid means blood in the abdomen. Interestingly, if we did a FAST on the other patient who was having fluid drain from his abdomen, the guy with ascites, he would have a quote unquote positive FAST too. We would see fluid in his abdomen. But in that setting, the assumption is totally different. We don't think that it's blood. We know that he has ascites and we're draining it. So it really depends on the situation that it's being used in. But in trauma, especially in this patient where we have this very clear history, we know that that positive FAST indicates blood. And the next step for somebody with a positive FAST in the setting of trauma is operating room, because she's got blood in her abdomen and she's going to need emergency surgery.
Blessings. And there's this one about fatherhood. Really stuck with me.
Voila, one red bead.
Yeah? How's it go?
Awesome job. That's not easy to do.
Jackson Davis, tox screen negative for cocaine, amphetamines, marijuana, PCP, benzos, and opioids.
We were talking earlier about how we can't assume for the agitated patient that it's from drugs. And in this case, this drug screen came back negative. Now, a drug screen is not 100% sensitive, meaning somebody can still have drugs in their system and it doesn't immediately show up in the drug screen. So it's still possible that drugs were the culprit. It just somewhat argues against it. And again, for a patient that's that agitated, we always want to take a step back and think about what else could be causing those symptoms, especially if there could be some more dangerous underlying medical cause.
My tooth, you got to do something.
We're gonna get right to that. Let's hang some IV antibiotics, 3 grams of Unicin.
No more talking. You got to fix my tooth.
I'm getting a little suspicious about this guy's tooth. If there's kind of swelling in the mouth, then we worry about the airway. We worry about a spreading infection into the floor of the mouth, which is called Ludwig's angina. Yeah, the fact that the pain keeps getting worse is kind of raising my suspicion a little bit. Curious to see what happens.
Hi, my love. I was listening to this couple argue, and they were yelling, both so angry. And I just wanted you to know, I was so wrong, and I'm sorry about all of it.
It's an incredibly sad case, and it's a good case for TV from an emergency medicine perspective, because you have this husband here who was the initial patient, has an unusual cause of their symptoms. We learned about hypokalemia, we learned about cardiac arrest and hypokalemia, fibrillation and resuscitation. And then you have this family member who initially refused treatment, which is super common. The wife's more focused on the husband, and then she ended up being sicker than the husband. There was a discussion earlier about, like, why didn't you evaluate her? Why didn't you insist? It's just a tough overall presentation and situation. She didn't want to be evaluated. We didn't know that she was the one with the more serious injury. Like, the whole thing just the way that it all fits together is academically and medically interesting and emotionally interesting in terms of, like, how the decision to care for patients and to focus on one patient versus another and how the family members play into that. Yeah, I hope that the wife does okay. I suspect, given how sick she was when she presented, that she may not do so well. And it would, again, we're writing for TV here, probably would be kind of a heart-wrenching ending if things didn't go well for her in the operating room.
Could that mass have been there for a while and only recently got worse?
Yes.
Could it be responsible for how much he changed? You know, his moods and tempers, he was...
Yeah, it's a really good point, and this also actually happens if somebody has a dramatic personality change. They should be evaluated by a medical professional. Any neurologist would do brain imaging to see if this person's personality change might be from something inside their brain. That really does happen.
Hey, we're starting to clear some space around here.
Yep. PTMC charge nurse, go ahead, medic ma'am.
As soon as he said we're about to clear some space around here, you know something is about to hit the fan. Charge nurse's phone rings. Yeah, nothing good is about to happen. Is this a drill? Yeah, I mean, I think we're about to see something interesting here.
Is this a joke? It's the 4th of July.
Yeah, everybody's standing around. What is this? This is how it goes.
Got it. Thanks. What's the issue? Contact didn't say.
Shit, it could be anything from a flooding toilet to a power outage. How long?
A couple of doctors probably got the holiday flu and they're understaffed.
Yeah, so other nearby emergency departments shutting down and traffic gets diverted to the one that's open. That also happens all the time. We usually call it going on divert. So another hospital's on divert and they're going to come here, or any patient that needs care.
Sounds like a betting grid to me. We are back.
Oh, I should have left last night.
Yeah, so thanks for watching. This was great. That does it for season 2, episode 3 of The Pit. If you enjoyed this video, make sure to like and subscribe. Looking forward to having my co-host, Dr. Ajay, back either the next episode or the subsequent episode.